Every year, thousands of infants are injured or die due to unsafe sleep. I am proud to announce that Cribs for Kids is celebrating its 25th year anniversary of helping every baby sleep safer. In 1998, we discovered in Pittsburgh that 90% of the babies who continued to die were found in unsafe sleeping environments. We decided at that time that if we provided cribs and safe sleep education to parents, we could change the culture and save babies' lives. By 2004, we had about 32 organizations around the country who were asking us to implement the Cribs for Kids program in their communities because they had seen that our rates had dropped so drastically during those years. That's when we decided that we would be a national nonprofit organization. At the beginning, we were using the Graco Pack and Play as our safe sleeping environment, and because we wanted a unit that had the safe sleep message on it, we got a manufacturer and we started to manufacture our own crib. We call that crib the Cribette, and it's not only a safe sleeping environment, but it's an educational tool for the parents. It has the ABC, Alone on My Back, logo embossed on the fabric, so it's a constant reminder to the caregiver that the baby should sleep alone on its back in the crib. We expanded then to produce wearable blankets and swaddles and other safe sleep materials, and through the sales of all of these products to our partners at discounted pricing, we were able to expand our organization. Cribs for Kids now has over 1,800 partners nationwide doing our program and purchasing our discounted products. We have several free programs we offer to our partners. They include the Hospital Certification Program, in which we certify hospitals and hospital systems for teaching safe sleep. The Managed Care Organization Program, in which we provide incentives to patients who perform all of their prenatal and postnatal visits. Our National Public Safety Initiative provides education and free cribs to first responders who are our eyes and ears in the community. The Safe Sleep Ambassador Program is a free online educational program that caregivers, daycare providers, or safe sleep advocates can become certified in infant safe sleep and receive a certificate. To date, we have distributed over 900,000 cribs nationwide. Our goal is to reach 1 million cribs distributed throughout 2023. You can help to change the culture surrounding infant safe sleep. Whether you're a community organization, a hospital, first responder, or managed care organization, or an advocate who cares about the safety of infants, we ask you to go to cribsforkids.org and join us in our mission to help every baby sleep safer.
Hello, thanks so much for joining us for Cribs for Kids 25th Anniversary Safe Sleep Champion Monthly Webinars. As you're coming in and we get started, you'll see your mic is muted and your camera is off. If you've attended or viewed any of our past webinars this year, you may know my name is Devin George. I'm the Program Officer at Cribs for Kids. Also, if you've joined or watched these monthly webinars before, you know that I'm typically the host, but I'm on vacation. Yay, summer. Kaylee Fagundes and Andrea Wilson are not on vacation, and they are still running the show behind the scenes as they normally do. While I'm sitting on the beach, the fabulous Judy Bannon, founder and CEO of Cribs for Kids, is taking on the hosting duties. That is great news for me, but also for all of you. Judy's going to share her years of experience with two other experts on infant safe sleep related deaths as this month webinar looks at the numbers. Before they get started, let me take a minute to give an overview of the webinars for those joining or watching for the first time. So today is the 5th of our free monthly webinars marking Cribs for Kids' 25th anniversary. Each month, around the 25th of the month, depending upon where it falls in the week, we'll talk with safe sleep champions from around the country about the work they're doing to prevent infant deaths and injuries from unsafe sleep. These webinars are live at noon Eastern, but they are recorded. just like this introduction and closing is of me, and we're going to keep going through all my flubs, so hang tight for that too. So the webinars are live at noon Eastern, but they are recorded. This gives you all the flexibility to view at your convenience or share with like-minded colleagues. The first 4 webinars are available for viewing on our website now, and today's session will be uploaded by about this time next week. Just go to cribsforkids.org, click on the About menu, and you'll find the link to our 25th anniversary page, and just scroll on down for those past webinars. And share away, please. For today's live webinar, we have chat available for questions and comments. Just wait till we finish talking with our guests to send your questions. We have found that in most cases, we answer questions over the course of the conversation. As the webinar ends, though, we'll invite your questions via chat, and we'll do our best to address all of them. If time doesn't permit, our team will stay on to the Zoom link to answer them once we finish the recording. So let's get started. I'll introduce our guests and then turn it over to Judy. So first is Dr. Mike Goodstein. Dr. Goodstein kicked off our monthly webinars back in February. He is a 30-year board-certified neonatologist. He's the director of newborn services for the Wellspan Health System and an adjunct professor of pediatrics at the College of Medicine of the Pennsylvania State University. Dr. Goodstein started the York County Cribs for Kids program and has been its director for the past 20 years. He's currently medical director for the National Collaborative for Safe Infant Sleep and is a member of the Task Force on Sudden Infant Death Syndrome. This is the team that authors the AAP recommendations for safe infant sleeping environment to reduce the risk of sleep-related infant deaths. Like I said, champion and an expert. We're also pleased to welcome Dr. Barbara Ostfeld. Dr. Ostfeld is a professor in the Department of Pediatrics at Rutgers Robert Wood Johnson Medical School. She's also the program director of the SIDS Center in New Jersey, which operates under a grant from the New Jersey Department of Health. She helped to establish this program in 1987 to serve the missions of bereavement support, research, and public health education. Dr. Ostfeld's research has contributed to the risk reduction guidelines of the AAP, and her public health initiatives have included the development of such education tools as SIDS Info, a free multilingual mobile phone app to help families retain and share tips for infant-safe sleep. Dr. Ostfeld also served as program director of the medical school's high-risk infant follow-up clinic, addressing the challenges to the well-being of preterm infants, including an increased risk of SIDS. She's been a member of the expert leadership group of the National Action Partnership to Promote Safe Sleep and was named a champion for children by the AAP's New Jersey chapter. She credits her 7 grandchildren with sustaining her commitment to infant well-being. So you guys, get ready to take some notes because I think there's going to be a lot of noteworthy conversation that's going to be discussed in today's webinar. I'm heading to the beach and we'll watch after, but Judy, take it away. Thank you, everybody.
Thank you, Devin. I am so happy to be joined today by 2 of my good friends. I met Barbara way back in 1989 when she had been with SIDS for a couple years, and Mike Goodstein and I have been doing this work since about 2003. So, Mike, I think we have a 20-year anniversary coming up. I'm going to start with Barbara. You and I have worked together for such a long time, Barbara, that it would take the full hour if we were just to talk about that. Can you give us a Cliff Notes version of how you started in this work and how that work has progressed to what you are concentrating on today?
I certainly will try, Judy. Thank you for inviting me to join you and Mike. You know, we've been all at this work for decades, and I think it's important to stop from time to time to take stock and sort out where our energy needs to go next. So, Judy, to answer your question, more than 40 years ago, I lost my son Daniel, not to SIDS, but to an incurable and fatal disease. And after a few months, I met a family whose baby had died of SIDS. And I came away feeling that somehow I was the more fortunate parent, because at least I had an answer, and that family never would. We may as well call SIDS, I don't know why my baby died syndrome. And for the rest of their lives, these parents will try to figure out the answer. So I began to work with families, and as you said, in 1987, we received a grant for the New Jersey Department of Health and established the SIDS Center of New Jersey. missions of bereavement support, research, and education to share whatever knowledge there was. And Judy and Mike, you may remember that in the beginning, there was very little knowledge. It was It's always more common in winter and more common in boys. So what do you do with that? But over time, we all learned that even though the causes remain unknown, the conditions that increase risk can be identified and have been identified. And all those findings became the evidence-based guidelines of the American Academy of Pediatrics, our Bible in this work. And these safe sleep guidelines are so well known now. They've made such a difference back to sleep, room sharing instead of bed sharing, having an uncluttered crib. The challenge that we all have now is that it's easy to change knowledge. It's much harder to change behavior. Knowing does not always translate into doing. So while we have to make sure the knowledge spreads, and we all do that, we also have to make sure that we help families overcome whatever barriers prevent them from acting on that knowledge. And Judy, Cribs for Kids certainly does this in making sure that the absence of a crib is not the barrier to safe sleep. Some of our current efforts involve the development of SIDS Info that Devin mentioned. It's our free mobile phone app. It's newly updated in the contained the 2022 American Academy of Pediatrics guidelines. It's in English and in Spanish. It has voiceover to solve any concerns about literacy, and it's been a powerful tool in the pandemic. We meant it for New Jersey, but we're excited and happy to know that it's being used all over the country. New Jersey was hit early and hard with COVID, and our on-site programs were off the table. So we gave nearly 200 webinars, informal ones, more formal ones. They've reached over 20,000 folks, and that has helped get that information out continually in spite of the lockdown challenges. And we work with public health programs in New Jersey to address the adverse social and health determinants that create the baby who's more vulnerable to begin with. I feel very strongly about that component, as you guys know. Those conditions have increased dramatically in the pandemic, and they've taken a toll. Our rates have remained among the lowest in New Jersey, but I have to tell you that gives me no joy to say, because when it comes to sudden unexpected infant death, low is never low enough.
I agree with you, Barbara, and that is at the heart of our mission, as you know. As you said, although the causes of so many of these sudden infant deaths remain unknown, we have learned that unsafe sleep conditions like prone or belly sleeping, blankets or pillows, adult mattresses, and bed sharing raise the risk. And we've learned that reducing exposure to these risks have made a huge difference. But we also know that other circumstances apart from unsafe sleep are also linked to higher rates of SIDS. You've published on smoking and on prematurity, for example, in the recent talks you gave at our National Cribs for Kids conferences. You describe other circumstances that create the more vulnerable baby. Can you tell us what you know about some of these factors and the role they play in infant sleep-related deaths?
Well, Judy, I'll pick up on the two you mentioned, smoking and prematurity. Smoking is a major risk without question, and its impact on the developing brain has been well worked out. We also know there's a dose-dependent relationship, meaning the more the fetus is exposed, the higher the risk. Every cigarette counts. And in March, we published a national study on smoking, and we found that the highest rates of sudden unexpected infant death occurred when the mother smoked throughout the pregnancy. But it's an addiction, and the most common pattern for a smoker was to do just that, to smoke throughout the pregnancy. In our study, we found somewhere between 70 to 80% of our maternal smokers, and depending on the group that they were in, continued throughout all 3 trimesters. But there's more to this story. In another study, we wanted to know if and how often obstetricians were asking their patients about their smoking habits. And at the start of pregnancy, great, over 90% asked, but the number dropped to below half by the time the baby was born. And what was more concerning to us is that fewer were asking about household smokers. And COVID is showing us they really need to. And we all know there's racial disparity in SUID rates and that the non-Hispanic Black rate is higher. Well, in New Jersey, we found that in the pandemic, there was a 68%, I'm going to be very precise here, a 68% rise in smoking among non-Hispanic Black household members between 50 and 64 years of age, grandparent age. And couple that with this, we also know that multi-generational households have increased in the pandemic. So it isn't just mom who needs to have the conversation and have help in quitting. And there's signs that smoking may be increasing, but asking for help may not be. There's a program called the North American Quitline Consortium, and it reported a 25% drop in calls, and yet cigarette sales were up in 2020, and it reversed a year-to-year trend downward. So there's much more work to be done. Preterm birth, you also mentioned that, a major risk factor. The shorter the pregnancy, the higher the risk. And a baby born just at the cutting edge between 24 and 27 weeks of a 40-week pregnancy has nearly 4 times the risk compared to a full-term baby. And we have racial disparity here too. The March of Dimes report card, the newest one, just came out, and it showed us that in the United States, the preterm birth rate among Black women is 52% higher than the rate among all other women. Now, how do you reduce the risk of a preterm birth? Well, for starters, it's crucial to have access to prenatal care. So it's a huge concern that the percentage of pregnancies that had 5 or fewer prenatal visits was much higher when there was a sudden infant death. And specifically, about 8% of pregnancies in 2020 had 5 or fewer visits, compared to 20% who lacked it in pregnancies that resulted in some sudden unexpected infant deaths. These are issues we can work on, and they make a difference.
They sure do. That's why we're so proud of our MCO program, because through our MCO program, the mothers receive our incentive gifts by attending their prenatal visits. So we like to say we're killing 2 birds with 1 stone. We're getting them to their prenatal visits so that baby's born at 9 months and not 7. And they're learning about safe sleepers. So when the baby comes home, they have a safe place to sleep. You know, Barbara, when Mike joined us for the first webinar in February, Devin asked him if he could wave a magic wand to make a change for our babies, what he would wish for. He included in his answer a reference to eliminating the disparities among population groups and accessing healthcare that has led to increasing the risk of a sudden infant death. We can see in the research that families with more social and health challenges are at a higher risk for a sudden infant death. We also saw some of these disparities become even greater during the pandemic. What have we learned?
Well, I completely agree with Mike's answer, and I'm going to have your wand do a couple of extra twirls around my wishes in a minute. There's a great quote from Del Monte Jefferson of the Center for Black Health Equity, and I'm paraphrasing. COVID didn't cause racial disparities, but it's exposing existing inequities in our healthcare and our social systems. Carrie Shapiro Mendoza, our colleagues at the CDC, just published on the changes in SUID rates from 2019 to 2020, which was the first full year of the pandemic. And they found that non-Hispanic white rates remained essentially the same, but non-Hispanic Black rates rose. And I took a bit of a dive into that data, and I found that the real jump was specific to non-Hispanic Black cases that were covered by Medicaid, which can be looked at as a measure of low income. Mm-hmm. COVID hit these families harder. And no matter how you measure the economic hardship, whether it's by inability to pay for basic necessities or by using up savings, the non-Hispanic white population fared better. And it's a well-established fact that the lower the income, the higher the rate of SUID. With poverty, there's less access to prenatal care, more food insecurity, poorer pre-pregnancy health, substandard housing, meaning if you're not a smoker, but your neighbor is, by golly, you are too. And higher crime affects outcome also. There's a study that was done a number of years ago. I think Brandy Joyner was on that, and it described a parent who was fearful of a drive-by shooting in her high crime area and fearful of other risks in her neighborhood. So she knew that bed sharing had risks, but she felt it was the safer choice and should have to make such a choice. But I have to ask you, Mike, please wave your magic wand over one more challenge. We need much more research to chip away at the boulder that we call unknown causes. All deaths have a cause, and when they come to be known, they could potentially be treatable and preventable. And the AAP called for more funding for studies on cause, and I think we all completely agree. We need something on the order of what happened over 30 years ago with the discovery of a genetic disorder called, get ready for this, medium chain acyl coenzyme A dehydrogenase deficiency, or MCAD. It accounted for a small portion of deaths that had originally been classified as SIDS. And infants with this disorder can't break down fat and get the energy that they need to run their metabolic engines. So when they're without nutrition, they can die suddenly. The miracle here is that it doesn't have to be a fatal disease. If it's identified, it can be treated easily. Though better techniques for diagnosing MCAD came along, and its role in explaining some of the deaths were recognized, and that slice of the unknown cause boulder was chipped off. We encouraged New Jersey to include it in its newborn screening protocols, and New Jersey became one of the first states to do so. We need more basic science. We need more research to help us understand the causes that we have not yet identified.
That's for sure. You made such good points, Barbara. And we know that breastfeeding helps reduce the risk of sudden infant death syndrome. And it surely is important for so many other reasons, as we all know. How did this important risk factor fare during the pandemic?
Well, not as well as we'd like. We learned that 1 in 5 hospitals in a national survey saw a drop in in-person lactation support. And even when it was there were shorter hospital stays, so it cut down on the time available to help women get comfortable with latching and other important details.
Mm-hmm.
Let's go back to the non-Hispanic Black Medicaid population that showed a rise in rates in the pandemic. In New Jersey, we saw an 18% decline in these infants being breastfed at discharge when they were without WIC support. And if we ask how important is breastfeeding, I think this answer is a powerful one. Nationally, non-Hispanic Black families on Medicaid who do not breastfeed have a SUID rate that's 55% higher compared to those who do. But the answer is not simple. When a parent elects not to breastfeed, there can be other challenges that are going on that also pose a risk. Maybe for economic reasons, a parent has to go back to work quickly and is unable to get the milk supply going. So there are many, many issues. And COVID, in a sense, has pulled back the covers. I think with COVID, Mother Nature is carrying out a very unethical experiment that no scientist would be allowed to do. But we're learning from it just how powerful a role the adverse social and health conditions play in a sudden unexpected infant death, and how leaky the safety net is for some of our most vulnerable families. Rebecca Carlin and Rachel Moon and Fern Howe just published an editorial, and I wrote down the title, Increasing Disparities in Sudden Unexpected Infant Deaths Reflect Societal's Failures. I think that says it all.
I think it does too. We're buoyed through our managed care organization program. One of our managed care groups has added a breastfeeding kit as one of the incentives that the mothers can pick, because we're finding that a lot of them have cribs or car seats. High chairs, the other incentives that we offer. So we put a breastfeeding on the go kit on the list, and we're excited that we have a lot of the Medicaid mothers who are choosing that incentive. So if that's a little bit of hope, I want to throw that out there. But it is so important. It always has been. I remember back in the 60s when I was having, and 70s when I was having my children, nobody breastfed. And I breastfed because my mother breastfed her children. So it's something we can make a cultural change by getting people to breastfeed, and then their children will take that as an example, and it will increase, we hope. So I'm going to switch gears here and go to Mike. Uh, Mike, your experience with infant safe sleep in the NICU is unparalleled. You recently published an article about the transition to the safe sleep environment from the NICU and presented at the NAN conference on this topic, helping healthcare team members learn how to be sure our most vulnerable babies are sleeping safely. Wouldn't it be great to have fewer NICU babies? You know, I like to joke with you and say that we're trying to put you out of a job, but really, what can expectant mothers do to reduce the risk of delivering a baby that would need care in the NICU?
Yeah, good afternoon, Judy and Barbara. What wonderful comments. I will share the magic wand with you anytime to try and get some improvement in these numbers that have been challenging and somewhat stagnant for quite some time. And yeah, I would love to see medical advances come that put me out of work. That would be absolutely fine. I'm getting ready to retire one of these days. No, not quite. But no, there's just way too many babies who are ill that end up in the NICU that can have impact on their entire life course. It certainly has dramatic impact on the parents and the siblings. So I wish there was an easy answer for this. Unfortunately, March of Dimes really started a campaign to kind of reduce prematurity rates. They have their report card coming out every year, and for a little while our numbers started drifting down a little bit, which was great. But in the last year or two, they've been drifting back up, and I think we're somewhere around 9%, almost 10% of pregnancies are not getting to term, which would be 37 weeks and beyond. For some babies, it's not a huge impact. At 36 weeks, a lot of babies will act like they're full-term babies, and there are some challenges to overcome. But the more premature or the more risk there are, the longer time you're going to be spending in a NICU. It is a life-changing event. And there are lots of reasons why babies end up coming early. If we had the answer to fix this, I think we would have done this a long time ago. There are so many variables here, but we know that healthy moms are more likely to have healthy babies. So you want to have good health during your pregnancy. And as Barbara mentioned, cigarette and also substance use has a dramatic impact on what's going to happen to that developing fetus and whether they make it to term or not. And Barbara alluded to the study that came out of Seattle Children's, where there's a direct correlation between the number of cigarettes you smoke and the risk of dying of SIDS. Well, it also leads to ending up having small for gestational age or intrauterine growth restriction, and those babies more frequently end up in the NICU. The babies that are exposed to narcotics during pregnancy often end up, whether they're in a NICU, depends on the paradigm you've set up in your hospital, but a lot of the babies who have neonatal opioid withdrawal syndrome, or NALS, what used to be called NAS, abstinence syndrome, end up either in the NICU or down on a pediatric floor or extended stays in the nursery. And there's lots of good work being done to reduce those stays, but some of those babies stay for weeks. And even though they go home with their symptoms under control, they often are affected by this for weeks to months after they go home, which can create a lot of challenge and frustration in the home environment. And then you worry about neglect and abuse for some of these children. Other things that moms should be looking at is obesity. and hypertension, and the two kind of go hand in hand. But if you're dealing with obesity during your pregnancy, you're more likely to get gestational diabetes, and that can create a lot of challenges for babies that are growing too quickly. They end up having to be delivered early. Those babies, there's something about the gestational diabetes that leads to a slowing down of the development of surfactant in the lungs. And if a baby is born surfactant deficient, then they're going to end up in the NICU, potentially getting intubated and getting treated with surfactant replacement therapy. And those babies can end up in the hospital for days to weeks because of that, even if they're close to term. Also with the hypertension, that often can evolve into maternal preeclampsia, which is a threat both for the baby and the mother. And we look at this maternal morbidity and mortality rates have been rising dramatically in this country. As a matter of fact, I do believe there was an elite, I don't know if she was a soccer athlete. I forget what sport she was, but she just died from her preeclampsia postpartum. Selena Williams almost died from misdiagnosed preeclampsia after she delivered her baby, postpartum hemorrhage. So all these issues that if a mom starts out unhealthy during her pregnancy, it puts both her and her baby at dramatic risk for ending up having unanticipated outcomes that can potentially be life-threatening. So we have to kind of go backwards, right? We always have to go see how far upstream we can go, right? Because we just want to hand somebody a fish to give them a meal. We want to teach them how to fish so they have meals, moving forward. I think actually the better analogy is the people in the stream that are kind of drowning, and you want to go upstream and see why are they in the water in the first place. So if you do not take care of some good health pre-pregnancy, right? Before you get pregnant, you want to make sure you're at a good weight, that you're not hypertensive, that you've quit smoking, that you've put yourself in the best health possible so that you can start with a healthy pregnancy and proceed down to completing that pregnancy at term. But if you really want to dig even deeper, right, we look at what are some of these environmental factors that Barbara was so eloquently talking about, right? Poverty and neglect and abuse have all kinds of impacts on the future mother while she's growing up. It affects her learning. It affects her emotions. We know it affects changes in our DNA structure, right? So we talk about toxic or chronic stress, adverse childhood events. So even when you're young, if you're being impacted by not knowing if you're going to be able to eat or not your next meal, not knowing if there's going to be heat in your home, if you're going to be living out on the street, or someone is abusing your mom, right? That has a dramatic impact on what you're going to be like when you're an adult, and that's going to impact your pregnancy and how you carry your pregnancy. So, the last time I spoke with you, the magic wand, we talked about getting rid of poverty, getting an even playing field, because this contributes to the disparities in health that you guys were talking about earlier in this session, that we've talked about in other sessions. So if you're living, it's a socioeconomic issue. If you're living in poverty, dealing with chronic stress affects how your adrenal glands function. It can lead to chronic hypertension. It can start to lead into some of those factors that lead towards obesity. And again, it just ties back into the health of the pregnancy. And then if you dig even deeper into this, that mom, even if you don't deliver a preterm baby, right? There's something called the Barker hypothesis, or the fetal origins of adult disease, which is a brilliant thing. There's David Barker, I think his name was. And when he first came out with this theory, he was just poo-pooed and ridiculed, but it turns out he was right. So these not just genetic factors, but these epigenetic factors that impact the fetus. And so depending on what time with that mom, if she is not eating properly, if there are other issues going on with this stress and the baby's not growing well, it sets up a genetic predisposition for what's going to happen to that child when he's an adult. So the
Wow.
impact of this may not even be seen in childhood. It will be seen in adult life, when that person then is more likely to be hypertensive, have cardiovascular disease, and obesity. So there's so many layers to this in terms of having a healthy pregnancy. And it always goes back to this cycle of poverty and deprivation that trigger it all.
Mike, that's so interesting. I never knew that the DNA could actually be changed
Mhm.
through adverse events in a child's life. And that's something I think more people should know about. I remember visiting you once in your NICU, and you had 28 babies in that NICU, and I was amazed. Have those numbers gone up through the pandemic, or are you seeing about the same numbers of babies in the NICU?
Yeah, it's interesting because I've heard different um, neonatologists have different takes on this. And at least in our experience, we didn't see a big jump up in our numbers. I think newborns, infants, and the NICU were relatively spared of this pandemic. Of course, there was impact. We didn't know at the beginning, so it
Right.
was we were just flying by the seat of our pants with this novel virus and not knowing what was going to happen. And this was really a bad thing. We were separating moms and babies because we were so fearful that the babies were going to contract this, whether it was at the end of pregnancy, having a vertical transmission, or after the baby was born, having a horizontal transition from the mom after birth. And we just didn't know how vulnerable the babies were going to be. So unfortunately, until we learned a little bit more about this, there was a lot of separation of mother and baby, which created all kinds of trauma for the family, but also had a negative impact on breastfeeding. And we always talk about the importance of breastfeeding for the health of the child, but also that protection against SIDS with anywhere from a 50 to 65% SIDS risk reduction if you're breastfeeding for anywhere from 2 to 6 months. And we know that early skin-to-skin care, that initiation of breastfeeding is so important for the continuation of breastfeeding and breastfeeding success. And so we had an unintended consequence there until we learned that we took the proper precautions with the mom, that she should be the baby should be staying with her. In the NICU, we just didn't, COVID didn't directly impact. Now, decreased prenatal care, that could have a negative impact in terms of increasing the number of babies we would see in the NICU. But I think the other thing that happened that might have counterbalanced this, and Barbara's husband's a neonatologist, I'd be curious to hear her comment if he's had conversations about this, is that moms who'd be running around working and doing a lot of stuff with the shutdown in the pandemic, all of a sudden, everybody was staying home. So if you're already at risk with hypertension issues, early preeclampsia, things like that, the recommendation is relax, get bed rest. Don't be running around stressing yourself out all day. And so I think for some moms, that actually was of a horrible pandemic, that was a positive thing, that they spent more time home, and some of those stressors of work during pregnancy were kind of diminished, and might have led to their pregnancy going a little bit longer. The other thing is, when you're getting a lot of care with our perinatology colleagues, and you're having frequent visits, when they start to see triggers for potentially risky things, they lean towards delivering a bit earlier, especially if there's preeclampsia or poor growth. I think with a lot less prenatal care, there were probably things that were brewing for some moms that would have caused them to be induced early, but they didn't. And hopefully in those cases, no harm came by extending the pregnancy longer. But that probably led to some babies getting delivered at term or closer to term than they otherwise would have if they had that additional monitoring. So I think there's a real mix of factors there that didn't lead to a dramatic change in numbers. But I know, Barbara, do you have any thoughts on that?
Well, there are in some subgroups, there has been a rise. And just to respond to the last thing you mentioned about the economics, some people could stay home and respond to the lockdown recommendations and others could not survive if they didn't have their jobs. So some groups protected and other groups not. But what I wanted to reflect on with you is what lockdown, what the whole pandemic did in terms of the impact on the family. Babies were getting discharged earlier. Many hospitals are reporting that. Actually, some cases it's still continuing. So you have a more exhausted parent going home sooner with less in-hospital education. And she's coming into a home where nobody can come to visit. Grandma and grandpa can't come and offer their help. Friends can't bring over food because there's lockdown. And exhaustion prevails. And people don't always make optimal choices when they're exhausted. And at 2 o'clock in the morning, that crying baby may be brought into bed, no matter how well intended, the plan was going to be. Or somebody may discover that if you put the baby on the belly, they might sleep a tad bit longer. A grandmother might suggest that. So we wound up having a whole mantra of sleep safer, not longer. That it was really so important to recognize that the fatigue is overwhelming, but it's transient. But a challenged sleep environment can be forever.
Yeah,
Some of the things we faced.
yeah, that's a great point. And I really think that that's absolutely true, that mothers didn't even want to stay 24 hours. They were so afraid that they would get COVID at the hospital that they didn't, home births went up, I believe, during this. And we had moms, we had to like try to twist their arms to stay long enough to take care of themselves postpartum. A fresh C-section, you shouldn't be going home at 24 hours. You're asking for trouble with that. And it reduced the amount of time we had for teaching. Everything was so compressed. And I think that had a huge negative impact. We're only getting to the tip of the iceberg of the numbers with Carrie Shapiro Mendoza's data, because that was 2017 to 2020. So she was looking at the trends before COVID and into the beginning of COVID. I think the numbers are going to look ugly when she collects the data from the second and third year of the pandemic, because I think you're going to see worsening of the disparities, because the people who need the education the most, who needed that safety net that got obliterated during this, where people couldn't have any face-to-face interactions. This impacted WIC, right? So they couldn't get education on breastfeeding. You couldn't have direct communication with the lactation counselor so easily. You couldn't sit and watch your breastfeeding and kind of correct your positioning. So I think we're going to see that breastfeeding numbers were going to be impacted by this. And if breastfeeding is impacted by this, the lack of safe sleep education, and then again, hitting these disparities where you're not having the home visitors with the people who need it, the affect this socioeconomic group, that the numbers are not going to be good, I think, when we look at this data for 2021 and even into 22, that the breastfeeding numbers are down. That's going to impact your SIDS, and then just not getting the education consistency, getting the respite that you need, getting the reinforcement that you need to hear from your providers, and just having these Zoom health sessions. It's just not the same thing. And so you just weren't getting the education, the reinforcement that's necessary to combat that tiredness and isolation that might lead you to make those decisions about sleeping together or prone sleeping that put the babies at risk. And I think the vulnerable populations, that's why you're seeing the increase in disparity in Carrie's data for 2020, that the one group that really took the hit, and you dug deeper in that to the Medicaid group, but those families that lost their safety net, we're seeing this worsening of disparities, which is just not acceptable.
I think also, Mike, I totally support your points. And I think one of the challenges is that this was not a one-size-fits-all pandemic. We got hit early and hard, other states had not, and so it went. So when you do the averaging over the whole country, you lose some of those nuanced differences that are very critical. I also feel that it's important for us to recognize how people try to problem solve with the best of intentions and how sometimes things can go south from there. We found that there was an 88% rise in home births in premature infants. You know, timing the delivery. Oh, I'm not ready to go yet. I don't want to even go to that hospital. Well, I'm so many weeks away from my pregnancy. This is probably just, my delivery. This is probably Braxton Hicks. It'll be okay. And good luck timing all of that. So there was a rise in that, and home births are fraught with so many challenges, as we know. So those have become issues that I think need to be further evaluated. Home visits, absolutely. The home visiting programs experienced a drop in numbers. So those are eyes on the event, people who can look and see, was there a crib in their home? Does the family need help? And all of those opportunities diminished in this period. So there's so much to unpack, and I think it's going to take a long time to look at every aspect of it. But in this conversation, I think we can all see and appreciate we're beginning to get a handle on all of the issues that have to be addressed, and that the pandemic demonstrated to us really matter. We knew it, boy, do we know it now.
Yeah, I agree. We at Cribs for Kids, that in March of 2020, when we were sent home, my main concern was, how are these moms going to get their crib and their safe sleep education? Because there wouldn't be home visits, they wouldn't be at the hospital being educated and receiving their cribs. So we started our Cribs for Kids at Home program, and we took our Safe Sleep Ambassador program, where our mothers could get online, watch a PowerPoint, take a test, become certified, and with that certificate, they would give it to their provider, and we would ship the crib from Pittsburgh to that mom's home. So we were able to get some of the moms taken care of and some of those babies into cribs, but we know that we missed so many of them. So I agree with you. When we look at the numbers post-COVID, I think we're going to be alarmed at what we see. Mike, getting back to you, what suggestions do you have for agencies like ours and other maternal and child health and public health professionals to promote prenatal safe sleep and SIDS prevention messaging?
Yeah, sure, Judy. Just before I answer that, I just want to circle back and complete another thought that I had
Okay.
when we were talking about avoiding preterm delivery. And another thing that's important is appropriate timing between pregnancies, because if you put your a second pregnancy too close on top of your first delivery, your body is just not as well ready to handle that. And that's known to be associated with then having subsequent early delivery. So I think that's important. And in terms of having good outcomes later on down the line, I'm really excited that there's a new, moms getting immunizations and then babies getting their immunizations are important in terms of SIDS risk. But there's an FDA panel is recommending approval for a new immunization for RSV, respiratory syncytial virus, that we know is devastating to our preterm babies after they go home, but can even make full-term babies really sick. So there's a lot of new exciting stuff on the horizon for that I think before the end of the year is going to be available to put in our toolkit to help with healthy babies that are going to be resistant to rehospitalization. So a direct an immunization that the mom gets, so she'll make antibodies to give the baby protective antibodies through the first 6 months of life. And then there's another product that is like the product right now, which I can't pronounce the actual name because they make all these things, Paxlovid, which is easier to say Synagis. So I use the trade name, so forgive me for that. But there's a new analog of this that's going to be, because the Synagis you have to give every month through the season, and there's a new product that's a slow release acting formulation of this that's one shot, covers 6 months. And I think and they're also marketing it for not just preterm babies that are highest risk, but for term infants as well. So this could be a game changer because RSV hospitalizations are huge. It's a very bad season this past season for that. Lots of adults getting really sick recently. That and human metapneumovirus has been really
Right.
bad for adults, children, and babies. So in terms of what we can do in terms of our outreach program, well, you guys already do a great job with this. It's consistency of messaging. I think I believe that moms and families can't just hear it from one source, right? When you look, I think Rachel has done a lot of really interesting research on this, on what are the influencers for new moms and just the whole network of relationships that they have, and which ones are the keys towards what moms do in terms of their decision making. So, we have important roles as healthcare providers, nurses. Parents listen to nurses because they're the most trusted of professionals around. Physicians and other clinicians, practitioners also have a bully pulpit because, again, it's a very respected group. So if you're not talking about it, then that's bad. Because here's an example, right? This was from Eve Colson's data from the follow-up from National Infant Sleep Position Study. And what she found was a few years ago that if you as a clinician recommended to a mother not to bed share, the likelihood of that mom bed sharing went way down. If you recommended bed sharing, obviously it would go up. But the thing that was striking in the data was that if you were kind of agnostic about it and didn't say anything about it, the mom was more likely to bed share. So you couldn't just not say anything about it. You had to say, we don't recommend this. Here are the dangers in doing it. And then you were like 40% less likely to do it. So having that message coming from different people and different techniques of providing that message. So it's got to be your visual message, right? If all your magazines for pregnancy show bed sharing and show bottle feeding, that is going to normalize that in the person's mind, that this is the normal behavior for that. So it's the visual images, the spoken word, what's written in text, the handouts you receive, whether it's coming through text messaging, through your provider in the hospital postnatally. There's great data on that from Ann Kellums and Rachel Moon and Fern Hauk on the Today's Baby, that repetition of messaging, consistency of messaging, and then not just providing that message for the mom, but providing it to all those people who are in the sphere of influence of that mother is critical. So we know that there's great stuff from the Be More for Healthy Babies program down in Baltimore. They made their messaging, they made one for the mom, so they made another one for the dads, and they made one for grandparents, and they made another one for other people who might be involved in babysitting and caring for your baby. So I think the wide audience and not just the mother is also really important. Multiple modalities, and then proper training for your home visitors, right? Because the people who establish a relationship with the mom are the ones who can really have the conversations. And again, it's got to be a conversation where you're not dictating and telling people what to do. Because if you as a clinician or anybody who's having a conversation with mom are shaming them in any way, you're done. You're not going to have an open conversation. They're just going to tell you what you want to hear and then keep doing what they want to do at home. So having those open, honest conversations and then really using techniques like motivational interviewing or the listening, observing, validating, and educating love technique are really critical to not just providing knowledge, as Barbara was talking about at the beginning of her part of this talk, but also changing behavior, because that's the hard part, and maintaining behavior change, because you can slip back too. So those are the things that I would recommend: working with others for consistency of message and doing it in multiple modalities is critical to the success of behavior change.
Great. Mike, how about the obstetricians? If moms are getting prenatal care, should we look to the obstetricians to support safe sleep education, or at least get their feet wet a little bit in this realm? I know this has been my thing forever, and I've talked to obstetricians and they say the mother is my patient, not the baby. But how can we broker a deal with them?
Man, I need the magic wand for that one, Judy. I wish I knew the answer. I think, you have to drill down to the local level for this, because we've reached out to obstetricians and obstetrical teams and groups, and I just think that the nature of ACOG is built very differently than the AAP. So I think it's a looser knit organization than the AAP is. And I think it just makes it really tough. And yeah, I think the obstetricians, they're not even comfortable, many of them, with promoting breastfeeding. And there's no reason for them not to be able to do that. I mean, it's so key, because we're really working at a handicap, to be quite honest, because we talk about having the further out from the delivery you get, pregnancy, right? Having a healthy baby. It's the same thing about messaging and getting moms thinking about what they're going to do with these decisions. I can't tell you still to this day how many times I go to delivery and I ask the mom, who's your baby doctor? And they're like, I don't know. I'm thinking, you had 9 months to figure this out. Come on now. You need to have a doctor for your baby. It's here now. But the same thing happens. You ask about, well, I'm not sure. I think I'm going to try it. We need to be more active in getting obstetricians. And if it's not the obstetrician, then their office staff and the prenatal educators. If the doc isn't willing to do it, let them aside. Let them say, hey, I am promoting this, but I don't have time to do it. But I want you guys in the room when you're doing your Leopold measurements, checking the weight, and you're having that casual conversation with the mom. I would love to trial a program like this, is to educate office staff and then make sure they have scripted messages at 20 weeks, at 24 weeks, at 32 weeks, to make sure that before they register for their baby shower, that they have the information for picking out the things that are good for their baby and avoiding the things that we know are not good for their baby, that are out there, that it's buyer beware, because we know there's just a ton of bad product out there. So I would love to be able to see us teaming up with the people talking to the mother at the beginning of the visit or afterwards, being able to give her a hand. Say, here are the items that are goods and not goods for your shower. By the time you get to 32 weeks, do you have a safe sleep for your baby, a safe place for your baby to sleep? If not, hey, we need to get you enrolled in the program now, because we don't want this happening when they deliver their baby and then everything's a scramble and you really don't have time to sit down and go through the education when they're exhausted. So I think those are some of the things that we need to work on. It's really a life cycle of safe sleep messaging, really. And that's why I love the dolls that you have, Sasha
and Sammy.
Sammy, thank you, Sasha and Sammy. I think that's so great, because if you get to kids and you teach them the stuff that they need to know as adults, then you don't have to unteach them the wrong things that they've learned and have already kind of solidified as beliefs in their mind. So you got to start young. Babysitter programs, a perfect place to do. Girl Scout programs, we've done this before, but getting the education on health classes and really hardwiring it early, so that they know the right thing, and you don't necessarily need the obstetrician to support you, but that everybody's on the same page, promoting the same message of safety, and that everybody knows that this is the truth and the way to go to make your baby as safe as possible.
Mike, I totally agree with you. We published on a high school curriculum, and the students that learned it were successful in keeping the information in their brains. And then they were tasked with going out into their communities and educating neighbors. And so because they were of the community, that information was well received, and there was a big jump up in knowledge in their neighbors and friends. And we were about to begin to work on it in public schools when COVID hit and everybody went home, but that's something we're going to be doing. We found with obstetricians that one of the messages that they resonate to right away is what I had talked about earlier. The window of opportunity to say don't smoke in pregnancy is over with the birth, and they realize how important it is to address that. And that was the toehold in, and we were able to begin to work very successfully. And the task force has done a wonderful job with the 2022 guidelines, because there are multiple statements in there about how important it is to educate from the start of pregnancy onward. I also agree with you about how important it is to involve the influencers. And we have all kinds of programs that get out to the grandparents and others. Everybody makes a difference. We also want to, and COVID has really brought this home, eliminate the middleman. And that's what our Safe Sleep app, our free app, does, because families can get it directly. And with those short hospital stays and those early discharges, that mattered more than ever before. And the nurses, short staffing and so forth, were so pressed that to have something that they could look at with families that presented a script made their job easier, and then they helped the families download it. And rich or poor, everybody has a phone these days. I also support what you say about redundancy. There's a study that looked at, what did you remember when you were told this 20 minutes after you get birth? Not much. They remember the conversation, but the details have to be repeated over and over, and that's what maintains the information. Consistent messaging, so important. We see what disinformation has done with vaccines and other health topics. When parents see a conflict of knowledge, they pull back. So we really have to make sure we're evidence-based, and all the folks who are involved with educating families understand the message, the reason for it, and give out the same advice.
This has all been so wonderful. I thank both of you for joining us today, and I'm sad that we're ending now, but I want to remind everyone that both Barbara and Michael will be part of our conference next May 7th to the 10th. So we'll hear more from them in depth on these subjects. And don't forget to put any questions regarding today's presentation into the chat. Mike and Barb will stay with us to answer your questions until the webinar ends. I'll now hand this over to Devin, who will give us our very important action items.
So thanks to everybody for joining us. I hope those of you who joined us today now know more than you did an hour ago. I'll learn something new from the Drs. Goodstein and Dr. Ostfeld when I watch this, when I get back from vacation, but I learn something new every time I talk with them. Thank you all for joining live, and thank you to those who will be watching later, like me. If you joined us before, you know that we close our webinars with 3 items: a call to action, opening registration for our next webinar, and finally, playing our lullaby, Just Baby. So first, the action item. We've had some pretty hefty action items over the past few webinars, from sharing our lullaby, becoming a Safe Sleep ambassador, signing up for infant product safety information, and bringing the Breath of Life stroll to your community. This month, we have an easy one. If you have found today's session valuable, this one will be even easier. The action item is to mark your calendar for Cribs for Kids' 8th Safe Sleep Conference, scheduled for May 7th through May 10th, 2024. Like our 2022 conference, it will be virtual. We have found that this allows for more people to present and more people to attend. The call for abstracts is scheduled for July, and registration will open in November. See, it's a simple one. Mark your calendar. So next is our July webinar, scheduled for Tuesday, July 25th at noon Eastern. Registration will open for this right at the end of this webinar. July's topic is Safe Sleep is Hard, where to find support and guidance. Kaylee Fagundes and I will be talking with Safe Sleep champions whose work supports families in their safe sleep commitment. We'll talk with folks from Charlie's Kids, Katie from Well Rested Wee Ones, and Amanda Simmons, who launched the evidence-based Safe Sleep Facebook group. It's going to be a jam-packed hour. Please join us. Finally, again, old hat for those of you who've joined us before, We close each webinar with Just Baby, a safe sleep lullaby. Like the Safe Sleep Ambassador and our video library content, it's available at no cost. The song, the video, the music bed, and the Spanish versions as the lullaby. So please share away and please use this in your education. As the lullaby plays, we'll stay on for any chats that we miss to answer any questions, and you can always reach us at info@cribsforkids.org. Thanks so much to Judy, Dr. Goodstein, and Dr. Ostfeld, and those of you who joined us today and those who you'll be watching later. Like me, we really appreciate your time and commitment. We hope you'll join us next month. Thank you.
No pillows, blankets, no toys, just baby.